Good morning, everyone, West Coast, East Coast, and to our international audience across the world. We're coming to you this morning from some different locations due to the major snowstorm that's occurring across the nation, but it takes a lot more than a snowstorm to slow us the didactic efforts of the ASMBS. My name is Adrian Dan, and on behalf of the ASMBS and the Bariatric Surgical Training Committee, I welcome you to this edition of the Fellows Project Lecture Series. Joining me this morning is a woman whose career is so hot she had to marry a fireman, Dr. Kunoor Jain-Spangler. And the West Coast broadcast will be moderated by Dr. Judy, Chen, Dr. Lloyd, and the chair of our committee, Dr. Matt Martin. So as always, every first Friday of the month, we try to bring together great experts from across the world for high-quality didactics for metabolic and bariatric surgery. Today, we have two great speakers who took huge topics and compacted them into 20 to 25-minute lectures. It was quite a deed, given the degree of the vast degree, rather, of the topics that they are covering. And I want to remind everybody to use the Q&A function in the Zoom application to post your questions. Please do not use the chat function for the questions. Let us know where you're from, who you are, and what your question is, and we promise to get to as many of those questions as possible. In addition, a reminder that there will be a separate Q&A session this afternoon after the West Coast rebroadcast of the morning lectures. So without further ado, I want to introduce our speakers. Dr. Faiz Shariff is a bariatric surgeon at WellSpan Health in New York, Pennsylvania. She'll be talking to us about the epidemiology and genetics of obesity and metabolic dysfunction. And Dr. Crystal Johnson-Mann from the University of Florida will talk to us about the pathophysiology of obesity and major comorbid conditions. So without any further delay, Dr. Shariff, we're going to have you start first.
It's truly an honor to be with you all and participate in this Fellows Project. So as you all know, obesity is one of the most significant public health problems of our times. Just how big of a problem? Let's explore in this talk. I have no disclosures. What's interesting is that obesity has been observed in human populations since its genesis. It has been both admired and condemned. The first picture you see here is of a 25,000-year-old figurine called Venus of Willendorf, discovered in Spain. Depicted here is an obese woman who was admired and venerated. Some have theorized that this represents a fertility symbol, an idolization of beauty. And throughout Asian history, you would notice this common theme. Obesity was considered a sign of success, power, and wealth. It was portrayed as an ideal body image, as seen in these Egyptian carvings and in these paintings of a Chinese emperor from Song Dynasty. So Song Dynasty was when the Chinese civilization was at its peaks. So for the longest time, it was seen as a privilege of the aristocrats. And in some cultures and tribes throughout the world, young girls were fattened up before marriage to make them more desirable. No doubt, extra fat stores provided a survival benefit during these food uncertainty times like war, famines, and infectious diseases. But the ill effects of obesity also have been well documented, starting from the Middle Ages in the writings of ancient Greece and Egypt. And in India, Hippocrates, the father of modern medicine, he identified it as a disorder leading to other medical problems. However, overall, the obesity rates were very low throughout history, except for the last century, to be precise, after the World War II. With technological advances came modernization of lifestyle, automation of transportation, resulting in decreased physical activity, hence decrease in energy expenditure. Globalization of food system produced more processed and affordable food, food that was energy dense and nutrient poor. Food was available 24/7, and that led to overconsumption. And to top it all, there was abundant availability of non-physical entertainment like television, Netflix series that we all are guilty of watching, and video games. As early as 1945, WHO recognized obesity as a disease with its own ICD code. And remember, at that time in the 1950s, the obesity rate in America was only about 10%. However, the medical profession around the world thought of this as a first world problem, even when WHO presented data to show otherwise in the 1980s. It wasn't until 1995 when WHO for the first time highlighted that for the first time in human history, that the world had greater problems with overnutrition than undernutrition. And 2 years later, WHO declared obesity as an epidemic, highlighting its crucial role in current unmanageable and escalating medical costs globally. So now let's look at global rates, okay? This data was collected by the Institute of Health Metrics and Evaluation. This is an independent global health research center at the University of Washington. And obesity here is defined as a BMI greater than 30, which is consistent with what we all use, and overweight as a BMI greater than 25. And the overweight rates include the obesity rates in this study. So the worldwide prevalence of obesity nearly tripled since 1975 to 2016. There are 1.9 billion adults who have BMI greater than 25. This is about 40% of the adult population in the world. The obesity rates are 13%. When you look at the regional trends, the Americas and Europe top the list, but similar rises have been seen throughout the rest of the world. In the study, they divided the world into 6 regions, and throughout the rest of the world, you can see the graph going up in the same direction. Overweight rates in America rose from 45% to 64%, and the obesity rate increased from 13% to 28%. Similar rise was seen in Europe, rising from 48% to 60% in the overweight rates, and obesity rates rose from 13% to 28%. Turkey in Europe and US in the Americas had the highest prevalence rate, and no surprise, France in Europe and Colombia in America had the lowest rates. What's interesting is that in low-income countries, obesity is generally more prevalent in middle-aged women from wealthy urban area. And in high-income countries, there's no difference between the sexes or between the ages, but it's more prevalent in the disadvantaged group, and we'll explore that a little later in this talk. Women generally tend to have higher obesity and overweight rates, except for young females between the ages of 20 to 44 years who have lower prevalence of overweight rates, just overweight, not the obesity, than in men from the same age group. This trend was reversed after the age of 45 to 49 years, and this may be coinciding with the menopause in women. The sex differences in the prevalence of overweight and obesity was maximal between 50 to 65 years of age. Middle age group in both sexes had highest prevalence of obesity. Now let's explore the rates in the United States. The data on disease prevalence comes from behavioral risk factors surveillance system. This is an ongoing telephone interview survey conducted by CDC and the state health department. So it's self-reported data. And we all know there's a well-known tendency where there's underreporting of weight and overreporting of height. Hence, the obesity rates may actually be slightly higher. Here is a map of the United States that shows the prevalence of obesity for each state. Green is the obesity rates less than 25, and dark red, maroon is the obesity rates of greater than 40. So if you look, obesity over the past 10 years, you can see more and more and more states are turning red. Right there. And the prevalence of obesity is highest in the South and Midwest, to be specific, in West Virginia, Mississippi, Oklahoma, and Iowa. Well, that's not it. What's depressing and disheartening is that not only are the obesity rates increasing in the United States, but the severity of obesity is also worsening. Simply put, individuals who have obesity are gaining weight at a more rapid pace than those who have not. In this study, further analysis of the same BRFSS data from 2000 to 2005, the prevalence of obesity increased by 24%. The prevalence of BMI greater than 40 increased by 50%, and the prevalence of BMI greater than 50 increased by 75%. So the greatest relative increase has been in the proportions of individuals with BMI greater than 50%. Now, this slide has a lot of information, so stay with me. This data is from National Health and Nutritional Examinations Survey called NHANES for short. It's conducted by National Center of Health Statistics, which is part of the CDC. It is a cross-sectional survey designed to monitor the health and nutritional status of individuals. And it's unique in that these are interviews and physical examination that are conducted. So it's a very objective data as opposed to the other data, which is more self-reporting. So in this, we see that the prevalence of obesity was highest in the non-Hispanic Black women at 55%, and men of Hispanic origin at 43%. What's interesting is non-Hispanic Asian individuals, both male and female, have lower rates of obesity, men at 10% and females at 15%. Now, this could be falsely reassuring. In general, for same BMI, Asians have a higher likelihood of developing metabolic disease than other races. So in 2002, WHO expert consultation panel proposed a lower BMI cutoff for Asian, proposing that overweight to be defined as BMI greater than 23 and obesity to be defined as BMI greater than 27.5. So just by lowering this BMI cutoff, it will translate to a greater obesity prevalence in these populations. Prevalence of obesity decreased by income increases. So the richer you are, the lower obesity rates. So it decreased by 8% from the highest income group to the lowest income group. The largest contrast was seen in women from higher socioeconomic strata compared to lowest socioeconomic ones, 30% versus 45%. Overall, men and women with college education had low obesity prevalence compared to people with just high school or lower graduation. In the past 4 decades, the obesity rate in children has quadrupled. The prevalence of obesity in children right now is around 20%. That's like 14.4 million children. And again, the same groups are affected Hispanic and Black kids more than the other races. And the highest prevalence is in the adolescent group. And what's more, the projections are really great. This is data from this study uses the data from both BRFSS and the NHANES survey. The authors here, what they did was corrected for the self-reporting bias by using measured data from the adults who participate in the NHANES survey. And their prediction, not really good. By 2030, 1 in 2 adults will have obesity and 1 in 4 adults will have severe obesity. And the prevalence will be higher in 60% or more of the population in 29 states in the country. Again, the same income, low socioeconomic strata group and Black adults and women will be more affected. And this was the projection before the pandemic. So this study, which was recently published in the CDC, talks about the effects of COVID-19 pandemic on children. Because of the pandemic, a lot of children and adolescents were spending more time away from the structured school settings, and families that were previously affected and had a higher obesity risk factors now had to deal with disruptions in income, food, and other social determinants. As a result, children and adolescents have experienced accelerated weight gain. The rate of BMI increased approximately double during the pandemic compared to the pre-pandemic period. Briefly, with the rise of obesity, the epidemic proportions, there is a concurrent rise in type 2 diabetes and hypertension, which results in increase in proportion of adults with metabolic syndrome. Prevalence of metabolic disease has increased from 25.3% to 34.2%. Low education level and advanced ages are independent factors for the increase in metabolic syndrome. And again, a point to note here is that metabolic syndrome in adults without obesity has remained stable at 16%. Now, we have seen that obesity rates are rising to the pandemic proportions. Let's understand why that is. It's in part or in major parts due to the obesogenic environment we live in. But not everyone in this environment develops obesity. Obesity results from the interaction between this environment and innate biological factors. And one such biological factor, or the most important one, is the genetic component that accounts for individual variation in body weight. So the initial gene discovery studies were hypothesis-driven. James Neal, a geneticist from University of Michigan in 1962, proposed this thrifty genotype hypothesis. The constant pressure of famine, war, and infectious diseases led to selection of genes that regulated metabolism efficiently. Polymorphism resulting from random mutation that predisposed to energy preservation were accumulated in our genome. We know that 70% of obesity is heritable. A child with one obese parent has a 3-time risk of developing obesity in adulthood, and a child with both their parents having obesity has a 10-fold increase in developing metabolic disease and obesity in the future. However, this Mendelian transmission theory does not explain why the sudden rise that we have seen in the past 40 to 50 years. Genes just don't change that quickly. We now understand that environment interacts with and affects the genes that we inherit from our parents. And the study of this interaction is called epigenetics. A good example to understand this interplay was seen in the Dutch famine. In 1944, after World War II, during the World War II, food was cut off to Netherlands by the Germans for about a year, and children born during this time period of undernourishment had a higher prevalence of metabolic disease, obesity and obesity compared to their siblings. Similar results were seen in the study of mothers with gestational diabetes. So the kids or the babies that are born to mothers who had gestational diabetes had 2-fold increase in developing metabolic and obesity disease than their siblings who were born when mom didn't have gestational diabetes. So both maternal under and overnutrition during the fetal life has profound impact on development of metabolic syndrome at later life. Epigenetics offers a logical explanation for increasing obesity prevalence over the past few decades without necessitating the radical change in the genome. We know that genetic code is homogeneous throughout the body, but the gene expressions, the expression of code across each different tissue and cells is different. Epigenetics modification can be thought of as differential DNA packaging that allows or silences the expression of certain genes across tissue. The environment and the gut microbiota can influence the epigenetic programming of parental gametes. And it also can affect the programming at later stages of life. How does this do that? It's either by DNA methylation, histone modification, microRNA mediated regulation. Going into each of this is just beyond the scope of this lecture. But, and these modifications can be passed on from one generation to another, either mitotically or meiotically. And there is evidence that shows, actually strong evidence that shows that perinatal and embryo fetal development period influences the human tissue and organs programming. However, this interesting study noted that weight loss intervention in obese individuals, either by surgery or by lifestyle modification, results in DNA methylation profiles that are very similar to lean individuals. So there's hope. lifestyle interventions can modify the genes, and these can be then passed on to the next generation. Over the past 2 decades, we have moved from studying a single candidate genes to a genome-wide association studies. Genome-wide association studies involves DNA sequencing of the whole genome in thousands of humans, and then identifying single nucleotide polymorphisms. And then using these single nucleotide polymorphisms and kind of correlating with the phenotypical or clinical traits. As a result of these studies and advances in other sequencing technology, we have a flurry of new discoveries. So obesity in general can be divided into 2 categories, polygenic obesity and monogenic. Polygenic is more common type, monogenic is rare, and that's the syndromic one. Monogenic obesity occurs early in childhood compared to polygenic obesity, which occurs later in life. And monogenic one occurs because of single mutation in one gene. Polygenic is a culmination of hundreds of variants in one or near many genes. Monogenic obesity has a strong genetic contribution, and the environment really doesn't affect it as much, whereas polygenic environment plays a huge role in the expression of these polymorphisms. Although these are 2 distinct forms of obesity, the gene discovery studies have convincingly shown us that they actually converge broadly to a similar biology. To be specific, it's a CNS and neuronal pathway that control the hedonic aspects of food intake. And the main control circuit for this is the leptin-melanocortin pathway. So let's briefly talk about this. Leptin is produced by adipocytes in response to food excess and refeeding, and the levels drop during starvation. This leptin then acts via the leptin receptors in the arcuate nucleus on 2 different set of neurons or neuronal pathways in the melanocortin pathway. One is the agonist pathway, the pro-opiomelanocortin neuron pathway, and the other one is the antagonist, agouti-related protein. The POMC neuron via melanocortin peptides like ACTH, MSH acts on MS4 neurons in the paraventricular nucleus. Now, if you remember, paraventricular nucleus has the appetite center, and that controls the food intake. So this pathway, when stimulated, decreases the food intake, and the AGRP pathway is an antagonist at the MC4R receptors and increases the food intake. So besides this, affecting this neuropeptide receptor system in the arcuate nucleus and the paraventricular nucleus, the leptin also modifies the synaptic connection by changing the structural plasticity and affecting the downstream functions. One way it does that is down here using the brain drive neurotropic factor to its receptors, the tyrosine kinase 2. It has effects on the hippocampus and limbic system. Again, those are involved with your memory and learning process. So now this is a busy slide, and I don't intend on going through all these genes, but these are the list of all the genes that have been implicated in early onset severe obesity, so the syndromic kind. And if you notice, just kind of briefly glancing through this, you can see that most of these genes involved in the melanocortin pathway, and any mutation in this results in hyperphagia and severe obesity. Now, let's go through this one. These are genes that have been most widely studied. As you can see, again, there is a lot of these genes are involved in the leptin-melanocortin pathway, but some are involved in energy balance, thermogenesis, and fat storage. One such most widely studied gene is the FTO locus. It was discovered a decade ago and has been widely associated with obesity. Despite all these studies, the causal variants or genes in the FTO locus has not been pinpointed convincingly. So this kind of highlights the difficulty in narrowing down the polymorphism that caused the problem, right? For one, they're all interlinked. and the introns that are associated kind of influence these gene expression, and the causal effects of these are very small to have a meaningful implication. Anyway, so coming back to the topic, FTO locus has 6 genes, a bunch of upstream and downstream introns that regulate this. The FTO plays a role in cellular nutrient sensing. Increasing its expression of this gene results in developmental shift, which converts the brown fat, or which are energy dissipating adipocytes, to energy storing white adipocytes, and it decreases the mitochondrial thermogenesis by 5-fold and increases the lipid storage. Besides this, the FTO gene again influences the brain regions which affect the appetite, the reward center, and motivation by this time regulating the ghrelin levels. And ghrelin acts through the same leptin-melanocortin pathway and influences the hedonic aspect of food intake. So why is it so important to study these genetics and epigenetics? Well, the hope is we can provide individualized patient care. As of now, there is this polygenic score for BMI, and the polygenic score kind of predicts your genetic susceptibility to obesity. And it is calculated by summing all the disease-causing alleles, and then they are weighted for the effect sizes. Currently, there are 2 million variants, and it only explains about 8.4% of the gene variation. So you can just see what a big problem we are dealing with. As of now, individuals with higher score have 4.2-fold increase in obesity rates compared with lower scores. But the current score is not reliable enough to be used in clinical care. But the hope, again, is that with more genome-wide association studies coming in and more increasing the sample size and refining and making algorithms sophisticated, we can eventually come up with a score. But it's important to remember that this score cannot just solely be based on genetics, right? Environment plays a huge role. So somehow these scores need to accommodate for the environmental role too. The other application is in developing treatment plans. So we have 2 good ones. One is the recombinant human leptin in leptin deficient individuals. Now, again, remember, these are early onset obesity, so it's very rare as is. But in those patients who have pure leptin deficiency, using leptin has shown to be have remarkable benefits. The other one is setmelanotide, which is an agonist at the MC4 receptor, and is used in individuals with POMC and leptin receptor deficiency. It acts or substitutes for MSH, and the treatments in these have been very promising. Besides using medication, we can advocate for lifestyle changes. It has been seen in one of these studies that increasing physical activity in individuals with common FTO gene variants can help mitigate the risk of developing obesity. So in conclusion, obesity is rising to pandemic proportions. Females, socioeconomically disadvantaged, non-Hispanic Black groups are at higher risk. There are 2 distinct forms of obesity, but both converge on a central role of the brain in regulating body weight. Leptin-melanocortin and the BDNF signaling pathway plays a main role. And hopefully by understanding the genetics, we hope to develop individualized treatment plans. Thank you.
Dr. Shariff, that was incredibly thorough and enlightening in a very short amount of time. As I prepare for the focused practice designation exam, I know I'll be reviewing not just your lecture, but also the one that will be coming up. I also want to point out that much of this general knowledge is relatively new, elucidated over the past decade or so, and we now know better than to attribute obesity to the patient's choices and behaviors, and to really understand the underpinnings of this terrible disease. So to move along, the next part of our lecture will be Dr. Crystal Johnson-Mann, who will discuss how some of these epidemiologic factors translate into the pathophysiology of obesity and the mechanisms of action of metabolic surgery. So without further ado, Dr. Johnson-Mann, take it away.
Thank you, Dr. Dan, and thank you to Dr. Jain-Spangler as well for the opportunity to speak about this. I'm going to try my best to not inundate you all with my coughing that is going on. I have no disclosures. So just as a quick overview, we're going to cover lots of things in this short period of time. So we're going to cover the pathophysiology of obesity. We're going to highlight the major comorbid conditions, as well as touch on the mechanism of action of metabolic surgery. So just as a quick review of adipocytes, so I'm sure we all kind of forgot this. So there are three actually main types of adipocytes. So white is the main cell type that can be found in humans. It is where the high energy yielding cholesterol esters and the triglycerides are stored. And then there's brown fat, which, from our medical school education, we associate more so with babies and infants as a mechanism for them to stay warm. And this is true. It's activated to be used for heat production after cold exposure. So adults also have it. And it's commonly located in places like the supraclavicular region, paravertebral, and mediastinum. And then there's another type, beige, which is thermogenic. It can be found scattered throughout white adipose tissue. It can be activated into brown adipocytes after cold exposure, exercise, or via endocrine hormones. So weight gain is not something that typically happens overnight. This is something that our patients experience that happens generally over some period of time. And so over this period of time, as weight gain is occurring, there are excess lipids that are distributed across several different body compartments. And so the main two places where excess adipose tissue gets deposited is in the subcutaneous tissue plane, which is the largest storage area that has multiple sites, of course, between the trunk and the extremities. And then there's the visceral area where, as we know, when we are operating on our patients, that we can sometimes see when people have a high load of visceral fat, as this is stored typically in the omentum, in the mesentery, and the perirenal areas. When you have excess adipose tissue and excess lipids, you also get an increase of immune cells such as macrophages. And then this leads to secretion of pro-inflammatory cytokines. So what are the consequences of increased adiposity from a cellular level? So adipocytes make adipokines, which are very much pro-inflammatory. And in addition to that, they also make additional hormones. And so the amount of adipose tissue, or in this case, the amount of excess adipose tissue that one has, influences the rate of secretion and distribution of the adipokines and these excess hormones. When you have an excess amount of adipokines and macrophages, this leads to what we kind of all see as the basis of metabolic syndrome, as this low-grade systemic inflammatory state. And what comes of this is that we also have additional effects such as hydrolysis of triglycerides, which then leads to the release of free fatty acids, increased SNS activity, increased activity of the renin, angiotensin, aldosterone system, and then actual mechanical stress. So you can actually have increased fat stores that actually cause physical stress in organs such as the kidney. So this leads us to insulin resistance and type 2 diabetes. So as a result of increased adiposity, there is, as I mentioned, an increased presence of these pro-inflammatory mediators. And as you have more and more of these pro-inflammatory mediators, this then interrupts normal insulin signaling, which then leads to insulin resistance and then the development of type 2 diabetes. A similar mechanism takes place for the development of dyslipidemia. So again, increased adiposity is generally at the root cause of this. This leads to increased lipid production, specifically very low density lipoprotein, which is very rich in triglycerides. The triglycerides that are in excess are then hydrolyzed, which then leads to, again, the release of free fatty acids. And when you have excess release of free fatty acids, this leads to the development of lipotoxicity and dyslipidemia. And we'll come back to lipotoxicity again shortly. So this, when we have the mechanisms of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, it all comes back to those lipolysis and the release of free fatty acids. But also in this process, you have accumulation of triglycerides within the actual hepatocytes. And so again, as I mentioned, lipotoxicity is at the root of all of this, because it's the lipotoxicity that then actually leads to hepatocellular death, inflammation of the liver, fibrosis, and then this pathological angiogenesis. And it's this ongoing inflammatory response that we see that is a driving force in the disease progression from non-alcoholic fatty liver disease to steatohepatitis to cirrhosis. So hypertension is a little different. Increased adiposity basically ramps up two systems. So it ramps up the sympathetic nervous system. You also have increased adipose tissue storage, again, visceral fat, around the kidneys, which is actually externally compressing the kidneys, which can also increase the activity of the renin, angiotensin, aldosterone system. There are additional factors. I'm not going to bring Gen X into this because this is really pathophysiology of obesity talk. But when you are also having a state of increased adiposity, we also have increased extracellular blood volume that these patients actually have, which leads to increased venous return and cardiac output. However, they also have a decreased blood flow reserve that can contribute to ongoing endothelial dysfunction, which can actually lead to arterial stiffening and thus begetting hypertension as the disease process. When it comes to coronary artery disease, we all may remember way back somewhere in the first year of medical school that atherosclerosis, the process of that actually begins in childhood. And so this is really from the standpoint of these macrophage foam cells and just the cholesterol esters from the things that we eat. And then that gets deposited within the arterial wall, which then leads to thickening of the intima layer of the arteries. Well, there's also additional lipid accumulation that can result in these fatty streaks. So if you were to dissect the arteries of young children, for instance, this is all very normal. All of them would have fatty streaks. However, the state of obesity accelerates all of these changes through several different mechanisms, including insulin resistance and this chronic low-grade systemic inflammation that I've mentioned previously. There's also the contributing factor of an endothelial dysfunction, which is primarily caused by a lack of availability of nitric oxide, because in this constant state of increased oxidative stress and inflammation. And then there's also this endothelial dysfunction that is also linked to microvascular disease. So obstructive sleep apnea, of all of the risk factors, obesity is the strongest. There's also age and genetic factors, as well as male sex. But increased adiposity increases one's neck circumference, as we know. It also increases the amount of pharyngeal soft tissue that is present. All of that can lead to increased upper airway collapsibility. Simultaneously, there's also reductions in lung volume, which can actually impede the caudal traction that exists on the airway, thus increasing pharyngeal collapsibility, which then leads to increased positive airway requirements, which can actually influence the severity of one's sleep apnea from mild to moderate to severe. These pro-inflammatory mediators that I keep talking about as a result of increased adiposity can actually also depress the central nervous system and actually lead to a decreased ability to control the airway from a neuromuscular standpoint. So this is a great graphic. It's a little busy, and I know that this is recorded, so you all can go back and look at this and potentially zoom it in. But it's a great sort of overview of what I've basically just talked about, how increased adiposity contributes to these multiple systemic things, as well as, increased adipokine synthesis, increased lipid production, increased activation of the RAS system and the SNS, as well as physical and mechanical stress, and all of the several downstream effects that happen across multiple different organ systems that ultimately result in the major comorbid conditions that we know are associated with the disease of obesity. So that's going to lead me to segue very briefly over to the mechanisms of how metabolic and bariatric surgery actually works, now that we've covered the pathophysiology of the comorbid conditions. And so one of the main ways that this works, so there's many different avenues through which what we do affects our patient's metabolic syndrome and improves it and leads to weight loss. But one of the things that's been discussed, of course, is caloric restriction, because in all of the operations, we're basically restricting how much one can eat. And the degree of caloric restriction varies by type of procedure. It has been shown that when we put patients on very low calorie diets, This has been shown to decrease the homeostasis model assessment insulin resistance, which is just one of the many mechanisms by which weight loss occurs. Malabsorption is probably the most debated. This is more evident. We know that there is some degree of malabsorption present in bone wide gastric bypass. This is perhaps more evident in the BPDDS, given the length of the common channel. We see decreased fat absorption, and this can be manifested when one measures fecal fat present. 6 months and 12 months post-operatively, we can see that there's an increase in the fecal fat present. However, there's no significant shifts in protein or carbohydrate absorption. So this is really kind of just going over fat absorption. And this is manifested by the fact that the overall reduction of combustible energy absorption is only 6 to 11%. Hormonal effects. So after bariatric surgery, we know that GLP-1, PYY, oxyntomodulin, and adiponectin are all increased. And then by contrast, we know that the effects of bariatric surgery decrease IP and leptin. There are also effects on bile acids that are where a situation where you actually have increased bile acids following either gastric bypass or vertical sleeve gastrectomy, which leads actually to improved glycemic control. And the way that the bile acids mediate their effects is actually either via the TGR5 or the nuclear FXR receptor. There are also eating behavior changes. So we know that a lot of our patients have disordered relationships with food, whether that's binge eating or poor choices of food. And so after bariatric surgery, one of the things that we start to see is that patients begin to have a preference for foods that are lower in fat and or sugar, as well as lower in calories. And this may be due to changes in taste or ill effects such as dumping syndrome, that people tend to stay clear of things that are higher in sugar. But there are also changes in the adipose tissue design. And so weight loss, of course, results in decreased excess adiposity. And so again, as the beginning part of the pathophysiology, we know that increased adiposity leads to increases in adipokine secretion in this pro-inflammatory state. So with weight loss, with decreased excess adiposity, you have alterations in this adipokine secretion, which of course then lowers one's systemic inflammation, which leads to improved insulin regulation as well as improved metabolic function. And there are some changes in the gut microbiota. You start to see reductions in the proportions of the Prevotellinaceae, Archaea, our Firmicutes, and Bacteroides. And then there's some other changes that are debated as to how some other factors actually feed in. This is another busy image, but it kind of actually goes over a great sort of sense of how you kind of tie this all together. So after bariatric surgery, we have decreased food intake. You have a decreased reward associated with food, which questionably changes one's energy expenditure. We have increased gastric emptying from the gastric pouch. You have increased insulin release from the pancreas due to increased insulin sensitivity. You have decreased glucose output from the liver. As far as adipose tissue kind of goes, again, you have changes in the white adipose tissue as well as the brown adipose tissue. Distally in the ileum, we have, again, increases in GLP-1, PYY, and oxy, and then you also have increases in bile acids. And then as far as how this affects the microbiota, this questionably changes the proportions of some of the baseline microbiota, which may or may not help change the energy absorption. So in summary, again, increased adiposity leads to increased production and hydrolysis, as well as pro-inflammatory mediators, activation of SNS, as well as the RAS system, and actual physical mechanical stress on various organs, which then leads to the development of metabolic dysfunction and systemic disease as we know it. And so bariatric surgery operates by several different mechanisms across several different systems that ultimately leads to the improvement of this metabolic dysfunction and results in weight loss. However, it's really important to remember that obesity, like so many of the comorbid conditions that are associated with it, requires lifelong management. And that is all that I have.
Thank you so much. Those were both fantastic lectures. I don't know how you managed to cover everything that you did in the time period, but it was really, really fantastic. We do have one question in the Q&A here, a very interesting topic. So how does bariatric surgery affect ovulation and fertility? It seems to improve almost immediately after surgery rather than after weight loss. And yeah, I'll hear your thoughts before I say anything on this.
I'm going to admit that's not an area that I've actually extensively looked into to understand the mechanisms behind that. I know it happens, but I couldn't really sit here and explain exactly how it happens, other than potentially decreasing the amount of excess adipose tissue, which then leads to decreased estrogen, thus interfering with fertility.
Yeah, that's what I was going to say. I think, we've all thought for a long time, adipose tissue has a lot of estrogen. As you lose weight, you decrease the amount of estrogen. It's like becoming not pregnant when your estrogen levels fall and you become more fertile. But yeah, absolutely. For the rapid fertility changes, I don't think we actually have a known mechanism yet. Adrian or Faiz, any thoughts on that?
I don't personally have any thoughts. I think there's a lot more. It's a lot more complex than that. And most likely, some of these mechanisms have not been elucidated, and some may never be elucidated. But certainly, we know from the clinical standpoint, the impact that it can make not only on PCOS but excess adiposity and excess estrogen production.
Right.
And I think also the fact that immediately after surgery, the insulin resistance in the peripheral tissue kind of goes down, so that may play a role. But yeah.
So I have a question. What are y'all's thoughts? So now we've talked about the genetics of obesity. We've talked about the mechanisms of action. Is this something, I know there are a lot of genomics companies out there. Are we going to be screening our patients from a genetic standpoint? Are we going to be picking their surgeries based on their hormone profiles and what they're going to have the best outcome with? Like, you're going to get a sleeve because you make a lot of ghrelin and genetically you're predisposed to that. So you're going to benefit the most. Do you think that's coming down the pipeline?
I think we are kind of close. I mean, we might need a little more time. The problem is, if you look at these studies, right, the sample sizes are still low. So there's an effort to combine the databases from Americas and the Europes, and hopefully then we increase the sample sizes, and then we can correlate these polymorphism. I know that there are quite a few pharmaceutical companies coming out with these, genomic testing. But here's the thing: if you have a positive result, then maybe you can kind of tailor make that. But then a negative result doesn't completely explain why you have obesity. So we are getting there, but I think it'll take a little bit more time. And remember, we need to add into the environmental factor too. It's not just the fact that you have this polymorphism, so now you're condemned to obesity, especially the common variety. So somehow we have to, in the algorithm, accommodate for the environment we live in.
I totally agree. I think that at some point, as medicine in general is moving to more individualized care plans, especially like in cancer therapies and oncologic regimens, I think at some point there will be a role for genetic testing and the treatment of obesity, helping decide which operation may work better for a patient in particular, if there is something that comes of that genetic screening. In the absence of anything that's helpful, I think we just continue what we're doing, remembering that, again, obesity as a disease process is multifactorial. So we really need to treat the entire patient and look at the entire external environment as a mechanism of really trying to help them get the best result.
Absolutely.
At this point, I think when I consult my patient, the advantage I find when I talk about genetics is that it takes away their guilt. And then kind of makes them more open to the surgery and helps them understand their own biology and how that can be modified. So I use it for patient counseling.
Yeah, that's a great point. The same way, we should be talking about obesity as a chronic disease in which we can have recurrences. I think the language of genetics really does help patients understand their disease process and kind of own it a little bit more and look for therapies for it. Right. Adrian, do you have any other questions?
So I do have a question that's a little bit more general, more clinical, and easier for you, Faiz. When our fellows are in practice next year and they tell their patients, look, this isn't your fault, There's some role for exercise, dietary restriction, and behavioral modification, but the majority of the reason that you're suffering from this disease is genetic. How do you sum it all up? What percentage can they tell their patients is attributable to genetics?
I think studies vary from 40 to 70%. But it's also important, like if you just start saying how this is a genetic disease, and then they think, oh, I was doomed to have this. But by bringing in the epigenetic component where you can say, hey, you know what, you have obesity, so your kids have a tenfold, like if one parent has obesity, then they have threefold likelihood of the kids developing obesity, and tenfold likelihood both parents are there. So I use that opportunity when I'm speaking to one person, then see where their husband are and how their kids are doing, and then bring in that component and say that by performing the surgery and by losing your weight, when you have kids, it affects them, and you can pass on these good genes to them after surgery. So it really, really helps in counseling the patient. I'm not just saying that this is only a genetic problem, but this genetic problem can be modified by lifestyle interventions.
Yeah, I think that's a really important point, not to tip the pendulum too far, because genetically we're not altering anything, right? When we do surgery. Right.
Exactly.
And the patients can't really think, oh, I'm being changed and I'm never gonna have this problem again. I do think it's important that they understand we're fixing the outcome, the downstream basically consequence of what potentially is this epigenetic problem for them. Any other tips that you give your patients when you talk about genetics, or any other tips to give the fellows on how they should broach this subject with them?
So first, I think a lot of our patients, when they come to us, have a huge guilt. They somehow feel that this is their fault, they have lack of willpower. So I use that study from the Greatest Losers talk, where the NIH conducted the study, and they say these people lost 100 pounds, and 6 years later, they gained all of their weight back, but then the calorie requirement went from 2,400 to down to 1,900. And for some reason, all my patients understand that. And then I say, what surgery does is kind of resets that button. But surgery just resets it. It doesn't help maintain that. So if you don't change your lifestyle, then you're going to end up here, maybe in 4 years, maybe 5, maybe 10 years. And then I quote this, I over quote this when I say 1 in 3 people gain their weight back. I know it's like 20%, but 1 in 3 sounds better. So to tell them that it's good enough to have the surgery and it'll help you. You'll have a honeymoon period, but you're going to start gaining the weight back if you don't change your ways. And I'm a big advocate for exercise and lifestyle changes. I even ask them to meditate. So it's like happy mind, happy body kind of a picture.
One other question for Dr. Johnson-Mann. We're talking about mechanisms of action, right? So we've seen all these different ways that we can affect obesity. From a medication standpoint, how do you counsel patients about that preoperatively, postoperatively? How does that work into your algorithm?
Yeah, sure. So it depends on what patients are really seeking. So preoperatively, primary operations, I have a similar conversation that Dr. Shariff kind of mentions with them. I remind them that this is a lifelong treatment. So they're going to get great success, provided they also put the work into it. But then to remind them that there'll be some degree of weight regain at some point. And what that looks like is really dependent upon the patient. It might be very minimal, or it might be everything lost plus some. When it comes to medications, I really kind of tell them a few things. There are some great medications on the market, right? As we know, some of those combination medications work much better than single agent medications. And then of course there's the off-label use of a few medications, but all of this requires intent and work. So medications are sort of like, to some degree, they're another adjunctive agent in the toolbox to help people get to their ultimate goal. But I like to sort of maximize the basic things first. So surgery and diet and exercise before we start adding on medications as an adjunct.
Awesome.
So one more thing, Dr. Shariff, I also use the Biggest Loser study. I feel it's a very powerful tool, but I do have to remind all the fellows who use that there was one patient there that kept their weight off. And that's
one patient, right?
And that's the patient that had bariatric surgery. So I always point to that
Yeah.
one single line. Another general question. This one's for Dr. Johnson-Mann. Again, very easy question. When our fellows are in practice next year, you still have patients ask you things like, I don't want the half operation, I want the full operation, or which one is restrictive, which one's malabsorptive. And I have to say, no. That was 10, 15 years ago. And we don't talk about that anymore because now we understand the mechanisms better. So in a nutshell, a patient asks you, Dr. Johnson-Mann, how does surgery work? What do you tell them in layman's terms?
Yeah. So in layman's terms, I basically tell them a few things, depending on the operation, because there's so many. I basically tell them a few things. One is that you're going to be able to eat less, which will help you down this pathway. But additionally, there's other mechanisms that occur really by alteration of your gut hormones. There is some degree of increased gastric emptying that you can see with gastric bypass inlet sleeve, as well as some degree of, obviously, of malabsorption, as we all know, because we all have our patients on lifelong supplements. But it's the interplay of basically the change in the hormones and the way we absorb nutrients, like the bile acids and everything else, that kind of really ultimately determines how weight loss occurs. My biggest thing in Florida is actually that patients are like, I want the least invasive operation. I'm like, they're both invasive. So I spent a lot of time pulling up pictures and counseling patients on this is all very invasive, trying to detail the differences between the various operations and kind of, going over risks, benefits, long-term sequelae, risks of things such as, marginal ulcers, weight regain, internal hernia, that sort of thing, nutritional deficiencies. And kind of bring that back to the patient and say, what are you comfortable with? What are your goals for weight loss? Number one, because I have a lot of patients who are very from different, I would say, Caribbean groups, sometimes who are very self-conscious about losing too much weight. So we have a real discussion about sort of projected and use the ASMBS calculator as far as like outcomes at 1 year and 30 days and that sort of thing, to try to better gauge and align what their ultimate goals are. Long term, if you just want to lose this much weight, but you want to keep your curves, okay. If you want to lose everything, okay. And this is how these operations may get you there. But again, reminding them it takes dedication and work. Like I can change your anatomy, but I cannot change your willpower.
Excellent. Very, very well said. Well, there's so much that we know that you guys have covered, but for those fellows out there with aspirations in research and academic surgery, there's so much that we don't know. It's a wide open field for research and elucidation of some of these mechanisms by which our operations work. So I'll turn it over to Dr. Jain-Spangler to see if she has any other questions.
I think we're all good. That was fantastic. Thank you both so much.
Thank you both so much.
Thank you for inviting.
Thank you.
We could not have had two better speakers to cover these important topics. And we thank you. We're looking forward to the afternoon Q&A session. And we're also looking forward to having you back with our program in the future. Thank you so much.
Thank you.
Thank you. Take care.
Bye.
All right. I really want to thank Dr. Shariff and Dr. Johnson-Mann. Those were fantastic talks. And fortunately, we have them both here with us again for the afternoon session. So thanks for pulling double duty. And for anyone listening who's planning on taking the new focused practice designation exam, I can guarantee you both of these topics are on the exam. There are genetics questions and there are definitely pathophysiology and hormonal questions. I'm here with my co-moderators from the Bariatric Surgery Training Committee, Dr. Judy Chen and Dr. Julianne Lloyd. And so I'll turn it over to Dr. Lloyd for the first question.
Great, thanks, Dr. Martin. Both talks were excellent. It was such a nice treat for us to review all of the information that you guys went over. So that was great, thank you. Dr. Shariff, I guess my first question is for you. As you were talking about the epidemiology, I really was just kind of shocked at the numbers that are being predicted for 2030 even. They're saying about 1 in 2 people are going to be struggling with obesity. Do these numbers actually take into consideration on patients who are undergoing bariatric surgery, or are they just looking at patients who've ever been diagnosed as being having obesity?
No, I don't think they take into account the patients who are undergoing bariatric surgery. So these predictions were made based on the surveys that were conducted by the CDC. And those surveys don't take into account, at least it's my understanding, they don't take into account surgical bariatric surgical procedures. And what's interesting is that it's just, these predictions were made in 2018. So that's before the pandemic. Now, with the pandemic, we know the numbers are rising, especially in one of my slides, I've shown the BMI increase in adolescents and children. So I think the numbers are going to be even more dire.
Yeah, it's really scary.
It is.
The next question in our box here is, I think, more for Dr. Johnson-Mann. And I continue to try have patients not focus on the scale, right? And there's new terminology of non-scale victories, which is very important in trying to really look at all the changes that you've described with the comorbidities. And so this question is, what's the total body weight loss considered successful weight loss? How far out from surgeries, 12 months to 18 months, that maximum weight loss is obtained? And I took that question as, different versus what you were describing, which I think we should always sort of remind patients to return back to. But the actual question is, what's the total body weight loss considered successful? And at what point?
That's actually really hard to answer, right? So it kind of depends on what the patient has as sort of a goal. So if the patient's goal originally was just to be healthier and they're not so concerned about the amount of weight that they've lost, they're more concerned about the metabolic improvement and coming off medications, then they may define success very differently than someone who's like, I want to lose 100 pounds. Historically, total body weight loss is always going to be lower than excess weight loss. And so we always quote numbers like 50 to 70% of excess weight loss, but total body weight loss is somewhere between 20 to 30% on the higher side. But again, it kind of boils down to what the patient wants and how the patient defines success. It's not so much for us to define, oh, you've hit this mark by 18 months, because the patient may not be pleased with that, regardless of what the scale says.
All right, great. Dr. Shariff, scary numbers as always, and they keep getting worse. The question is, the epidemiology has shifted so significantly, and we're still using BMI 25 as quote unquote normal, BMI 30 as obese.
Right.
Is it time that we should be shifting our definitions and cutoffs of even what we call normal, or do we still need to keep that and say, well, that's still, our healthiest BMI?
I mean, the problem with BMI, as you know, is like, it's just kind of a weight over a height. And it doesn't take into account body composition. It doesn't take into account comorbidities. And there have been racial differences. For example, Asians have this low BMI obesity rates and overweight rates. I think obesity rates are around 10% for men and 15% for women. And we know that Asians in general have higher propensity for metabolic disease with a lower BMI. So I think, yes, WHO kind of proposed a lower cutoff for BMI to qualify as overweight and obese in 2002. And a lot of countries like China, Singapore, if you look at their statistics, they use a lower BMI. And I think it's time in America, we kind of, with the diversity that we have a different cutoff points with BMI and maybe accommodate for comorbidities to qualify, for defining obesity. BMI is a little bit outdated.
All right, we have another question from the audience from Cesar Ochoa. And this looks like Dr. Johnson-Mann, more suited for you. So you talked about changes in the microbiome, which I think is a huge area of interesting research. Do you know or do you suspect, are those changes due to the weight loss? Are they due to dietary changes after surgery, or are they due to the neurohormonal effects of surgery?
It's not an easy thing to answer. I don't think we really fully have elucidated the mechanisms and how those changes really take place. It's definitely multifactorial. We know in studies of non-obese individuals and compared to patients with obesity, there are changes, there are differences in the gut microflora. that exists between those two different patient populations that may contribute to the onset of the disease of obesity. And so this is an area of ongoing research. Certainly it's likely a factor of everything associated with bariatric surgery and not just one item like weight loss.
And then do you know, are there major differences based on the procedure type? You know, does the BPD have a different change in microbiota versus the sleeve?
Yeah, that's actually a really interesting question. I would hypothesize that you would see a difference in more malabsorptive procedures like BPDDS versus the sleeve gastrectomy, but I'd have to check the literature to see if that actually has been teased out.
Yeah, I think that makes sense, especially with the bile acid. You know, it's all quite intertwined with so many different types of mechanisms. Absolutely. I have a question for Dr. Shariff in regards to genetic testing. You know, it's not readily available. You know,
Yeah.
For me as a surgeon, when someone's not really losing weight at 3 months, you know, there are medications, but then it's still so challenging. And then you start to just think, gosh, am I missing a genetic
Right.
thing? And then if I did try to order it, how do I do it? These medications for, what is your thoughts? Have you been able to get it accomplished? Do you have a geneticist who does it in your practice or anything?
No, we are very far away from kind of translating this into a clinical practice. I mean, I know there are companies that are producing these genetic testing things, but you have to remember there are over 2 million variations of polymorphism, and each with a small effect size. So it's very hard to kind of pinpoint, oh, this gene, if it has this polymorphism, causes obesity, because the effect sizes are very small, and then you have the environment that plays a role. I mean, it's different with early onset obesity, where, you know, it's just a single mutation, it's easy to pick it up, and then for those, you can kind of have a testing panel. But when you have like millions of them, how do we develop that? There is a polygenic score, which kind of takes into account all the alleles, the polymorphism in all the alleles associated with obesity. But even that accounts for only 8.4% of obesity. So if you have any of those, then yes, your chances of having obesity are higher. But if you don't have them, that doesn't mean that, you know, you don't have any other genetic problems going on. It's a hard topic to kind of completely understand, I think. And our knowledge is just at infancy. It needs a lot of maturing before we can start using that in clinical practice. But I'm very hopeful that it's going to happen soon.
So I can actually foresee, maybe decades from now, patients coming into clinic and we're taking a sample of their blood and running it through this genomics program. And we can actually figure out what's the ideal individualized treatment approach for patients based on their genetic profile. Yeah.
And I think that's going to be across the board, right? Like for cancer patients, for obesity, any chronic disease, we all know it's multifactorial. So there is going to be genetics that plays an important role. And I hope that the individualized scores that we will come up with takes into account the environment the patient lives in and like their lifestyle. But that's the hope, right? We have something that will guide us into which surgery would be most effective in these patients, or which other interventions would be.
All right. Dr. Johnson-Mann, you gave some great information about, all the pro-inflammatory changes with obesity and the neurohormonal imbalances. And you can see these patients in clinic, and you have the one who you just know is super pro-inflammatory. BMI is above 50, markers are through the roof, and then you have the ones that are less severe. Do you use that at all in terms of selecting which procedure you're going to recommend for those patients? And do you think the procedures have a differential effect on that inflammatory process?
Yeah, I think that's a great question. So, my partners and I take a very patient-centered approach to how we help them select procedures. Essentially, I like to always just sort of start off with we have a whole seminar that we have online. So I always ask the patient, do you have any questions from the seminar? Is there a particular procedure that you have an interest in? Because quite frankly, I think we've all experienced this. There are some patients who come in and they are very adamant they want a particular procedure, and they are really not willing to change on that, or they're willing to go elsewhere to get what they want. And that's fine. I honestly, I take the approach of I try to, do what's best for the patient, and I'm just very blunt with them. So I usually take that information first, and then I kind of look at how they're structured essentially. And does, the disease of obesity, does it run in the family? How is their, their excess adiposity? Are they more pear-shaped? Are they more apple-shaped? Like, where do they store it? Because this gives me ideas as to, are they going to have increased loads of visceral fat versus do they kind of hold most of their excess adiposity in the subcutaneous plane? When it comes to metabolic dysfunction, certainly when people come to see me and they have significant elevations of cholesterol levels and they have very difficult to control diabetes, we do have discussion about room like gastric bypass, not infrequently, but everyone's not up for that initially at that sort of initial interaction. I do try to basically give them the pros and cons of all the operations that we offer. Pitfalls, expected, improvements in various things. And yes, you will see marked improvements in these disease process with these operations compared to a sleeve. But I think the general trend, as most of us are seeing nationwide, is that most patients come in wanting a sleeve, honestly. So unless there's a direct contraindication to that, we have that discussion as well. I do a pretty extensive upper endoscopy evaluation to make sure they don't have underlying Barrett's and that sort of thing, so that we don't have issues down the line. But honestly, I try to take the whole patient as a whole when I'm doing these evaluations, and I don't want to come across them not listening to their concerns and that sort of thing. And I just sort of offer up that this is our armamentarium. I think in your particular situation with your disease profile, I think this operation may benefit you more, but ultimately it's the patient's decision.
Great. We have one more question from the audience, and it looks like it's directed at Dr. Shariff. So it says, do patients in low-income populations have less access to bariatric surgery, or are they being denied care by virtue of cost, or what exactly do you think are the contributing factors why low-economic patients are suffering more?
I'm sorry, you cut off, so I really didn't get the question.
Oh, it's just asking about low-income populations and the higher proportion of obesity. Like, how do you explain the connection?
I think it's, again, multifactorial, starting off with the environment. It's the kind of food they eat, which is energy dense, low nutrient food. So from there to lack of awareness, lack of education, lack of access to care. I think this has been very well documented, how the socially disadvantaged groups are being affected with most of the chronic diseases that we have. It's multifactorial, starting from the childhood with the kind of environment they live. So I think to answer this would be, like I said, in general, lack of access to primary care would be the biggest factor, I think.
Do you think these patients also have lack of access to bariatric surgery?
I'm sure, yes. I can't quote you on papers, but there was a talk on ASMBS earlier where we had discussed this, where so, people from lower socioeconomic status have decreased access to, bariatric surgeries.
All right, maybe either of you or both of you. This is a controversial discussion we actually just had here. Would you offer bariatric surgery to a patient with monogenic obesity? That's what we said.
That's a tough one.
Depends. And I think bariatric surgery, it's not just the surgical aspect of it, right? Like, they need to be able to be compliant with the diet that both goes pre-op and post-op. So it depends on the support network. I think it will have to be an individualized decisions. I'm not completely opposed to the idea. Recently, I did a surgery on someone who had autism, but then they had a good support, and this patient was wheelchair bound. So yes, it's not the syndromic obesity, but and then the patient was off the wheelchair, and the parents were happier because they could take better care of him. So I'm not completely opposed to the idea.
Yeah, I agree with Dr. Shariff. It's a very individualized discussion and weighing risk benefits and the support system is going to be key.
All right. Well, I think we're at our time. I really want to thank our two speakers. Fantastic. And again, thanks for being with us for both sessions. I want to thank my co-moderators, Dr. Chen, Dr. Lloyd, and of course, Dr. Adrian Dan, who's put this whole lecture series together. So we will see everyone next month. Thank you.
Thank you. Thank you for having us.
Thank you so much for having us.
Take care, everyone.
Bye.